Welcome to the deep dive. Today, we are taking on one of medicine's most, well, miraculous yet really taxing processes, organ transplantation.
It really is.
But we're going to zero in on the long game, the critical, comprehensive role of physical therapy management throughout that entire journey. We're drawing on some fantastic material presented by Gretchen Corcoran, who's a PT, DPT, and a geriatric clinical specialist.
Yeah, and that GCS, the geriatric designation, that's key. It tells you we're looking at complex multi-system management, often in an older population with a lot of comorbidities.
So we're going way beyond the OR today.
Oh, way beyond. We need to explore the biology of rejection, the intense criteria for even getting an organ, and then how PT really bridges that gap between just surviving the surgery and actually living a functional life.
I think that's a great scope. And before we jump into the system itself, let's nail down some of the language because the sources are really clear that not all transplants are created equal.
Absolutely. The vast majority of what we'll talk about, heart, liver, kidney, those are allografts.
Also called homologous, right?
Exactly. It's a transfer of tissue between two genetically distinct members of the same species. So, person to person.
And you contrast that with transfers that use the patient's own body, which we see all the time.
Right. That would be an autologous transfer. So you're transplanting tissue or blood products back to yourself, like a skin graft or your own blood. But then you get the really science fiction sounding one, xenogenetic transplant.
From another species.
Different species, yeah. And while full organ xenotransplants are still pretty experimental, we actually use components all the time. Pig heart valves are probably the most famous, or porcine clotting factors.
That distinction's important. And, speaking of placement, the actual surgical approach matters too.
It really does. It's either orthotopic or heterotopic. Orthotopic is what you picture. The diseased organ comes out, and the donor organ goes right back in its place. Think heart or liver.
Okay, a direct replacement.
A direct replacement. But heterotopic is different. The recipient's native organ actually stays put, and the new organ is placed somewhere else. The classic example is the kidney transplant. The new kidney often gets tucked down into the lower abdomen or the pelvis.
Which brings us right to the logistics of this whole thing. I mean, it's an incredible system. In the U.S., it's all managed by the United Network for Organ Sharing, or UNOS.
Yeah, and the UNO system is massive because the stakes are, they're life and death, and the resource is just so scarce. The criteria for distribution are incredibly rigorous.
The sources mention these complex scoring systems, MELD, PILD, EPTS. Can you break down what those scores are actually measuring for us?
This is so crucial because these scores are what dictate who gets an organ. So MELD is the model for end-stage liver disease, and PILD is the pediatric version. They basically predict short-term mortality risk.
So a higher score means you're sicker.
Sicker, and you need that liver faster.
Right.
Exactly. For kidneys, they use ETTS, which is estimated post-transplant survival. It's a measure of how long that new kidney is likely to last. So these scores, plus blood type, size match, wait time, it's all crunched together to prioritize the sickest, best-matched patients.
So urgency is literally baked into the math, and that urgency is just magnified by the biggest constraint of all, the clock.
Oh, the clock. The preservation time limits define the entire operational tempo. Think about it. Once an organ is procured, that clock starts ticking. For a heart or a lung, you're talking only 4 to 6 hours.
4 to 6 hours, that's it.
That's it, to get it implanted and working. And that drives everything. Organs are offered locally first, then regionally, and only nationally if there's no match nearby.
A liver gives you a little more time.
A little more breathing room.
Yeah.
Up to 24 hours. And kidneys can go 48 to 72 hours. But that 4 to 6 hour window for a heart, the coordination required is just astounding.
Especially when you compare it to, say, other tissues.
Totally different world. Corneas can last 5 to 7 days. Banked tissues, like bone, can be preserved for years. A living, metabolically active organ just changes the entire game.
Okay, so let's get into the key to success then. The science of matching, or what we call tissue typing.
Right. Histocompatibility. This is the absolute foundation of preventing rejection. The team is trying to match what are called human leukocyte antigens, or HLAs.
HLAs. Think of them like ID badges on your cells.
That's a perfect way to put it. They're highly specific identity markers. If your immune system sees too many unfamiliar HLA markers on that donor organ, it just mounts an attack.
Yeah.
So you match the ABO blood type, the RH factor, and then you get the best HLA match possible. The better the match, the less foreign the organ seems.
Which means a weaker immune response and a better chance of success.
That's the hope.
So that process minimizes the battle, but it definitely doesn't eliminate it. Let's shift to the patient's condition before the surgery. They're waiting for that call, but life is. It's not normal.
Oh, it's far from normal. Patients waiting for an organ are living with advanced chronic disease. They are systemically depleted. A kidney patient with end-stage renal disease is often just exhausted from the cycle of dialysis, the fatigue.
And what about someone waiting for a liver?
If they have cirrhosis, they're dealing with intense muscle wasting. That's myopathy. And often altered mental status because of toxins building up. Heart and lung patients have profoundly decreased endurance. I mean, they're starting this transplant marathon already exhausted.
And that deconditioning is exactly what PT has to start addressing before they even get to the OR.
Precisely. Pre-transplant exercise is all about building up a functional reserve. The PT goals are promoting mobility and specifically strengthening the big proximal muscles, your glutes, your quads, your trunk.
Why those specifically?
Because they know the high-dose steroids coming after the surgery are going to attack those areas first and hardest. So weight training before surgery isn't just for strength. It's a preventative measure against that future muscle wasting.
Okay, so the patient gets the call, they rush in, surgery happens, and post-op, the risks are immediate. Beyond infection, the big one is hyperacute rejection.
Hyperacute rejection is an immediate immune catastrophe. It happens minutes to hours after they reconnect the blood supply. Basically, preformed antibodies in the recipient recognize the new organ and trigger this aggressive response that just clots it off.
A medical emergency.
A total medical emergency. The organ has to come out immediately. Now, the good news is, with today's rigorous testing and cross-matching, this is pretty rare. But that risk defines that immediate post-op window.
Which leads us right into the long-term fight, rejection and the inescapable trade-offs of immunosuppression. This defines the rest of their lives.
It really does. The most common type of rejection in the first 6 months is acute cellular rejection. This is where T cells and antibodies are actively attacking and damaging the graft.
And the treatment for that is aggressive.
Incredibly aggressive. You're talking about things like IV intravenous immunoglobulin, plasmapheresis, even high-dose chemotype drugs. Anything to just silence the immune system and save that organ.
And if that low-level battle just keeps going, it can turn into chronic rejection.
Yes, and that usually starts after 6 months. It leads to this slow, progressive organ failure. It's caused by constant low-level inflammation that leads to fibrosis and chronic ischemia. The new organ essentially slowly chokes itself off, and that kind of damage usually doesn't respond to more medical therapy.
The sources also point to a really unique risk, especially for bone marrow recipients. Graft versus host disease, GVHD.
Yeah, this just flips the whole script. Instead of the recipient rejecting the organ, the T lymphocytes that are in the donated bone marrow recognize the recipient's entire body as foreign.
And they attack the patient.
The graft attacks the host, exactly. It's a profound systemic failure. You see severe skin rashes, jaundice, debilitating GI issues like nausea and diarrhea.
How do you even treat that?
With extreme immunosuppression. High-dose corticosteroids like prednisone and drugs like cyclosporine and tacrolimus, which are basically T-cell blockers.
And this brings us right to that core challenge, lifelong immunosuppression. Usually a 3-drug cocktail every single day for the rest of your life.
That cocktail is typically a calcineurin inhibitor, an antimetabolite, and a corticosteroid. And it's important to know what these are doing. A calcineurin inhibitor, like tacrolimus, blocks the T cells from even getting the signal to attack. An antimetabolite stops the immune cells from multiplying so quickly.
So you're blocking the signal and you're limiting the army.
That's the idea. It keeps the graft alive, but the side effect profile is just staggering.
Staggering.
It is. Infection is the leading cause of death in the first year. For a physical therapist, this means strict protocols are non-negotiable. Meticulous hand washing, maybe masking, obsessive cleaning of equipment. You're treating profoundly immunocompromised people.
And the long-term risks are enormous. We hear about things like atherosclerosis or diabetes, but what about the musculoskeletal risks? Those seem to fall right in the PT's lap.
They absolutely do. This is where the price of the graft becomes the PT's problem. You see neurotoxic reactions like tremors, but critically, you get these steroid-induced myopathies, severe muscle wasting, especially in those big proximal muscles we talked about.
And the bones.
And the bones. Long-term steroid use leads to a massive risk of osteoporosis. The sources note that vertebral fractures happen in up to 35% of these patients. That means every single exercise, every transfer, has to be planned around fragile bones and weak muscles.
That sounds like a constant clinical tightrope walk.
It is. You have to push them to rebuild muscle, but you could accidentally cause a fracture.
So how does that acute post-transplant PT phase even begin?
It begins fast. TT's usually consulted on post-op day 1, or POD 1, as soon as the patient's alert and extubated. The immediate goals are just survival and basic function, getting them sitting up, transfers, ambulation.
And what are you monitoring minute to minute?
Vitals, constantly, especially blood pressure. You have to maintain adequate tissue perfusion to that new, very sensitive organ. And then there's meticulous line management IVs, central lines, and of course managing that huge incision.
Let's talk organ specifics. The rehab for a kidney recipient must be so different from a liver recipient.
Totally different. A liver transplant involves a huge abdominal incision, and that dictates everything in the acute phase. Resistance exercise and lifting are strictly forbidden for 6 to 8 weeks.
And the PT's role.
We're working to prevent pulmonary complications because it hurts to take a deep breath. We manage post-opocytes, which is fluid in the abdomen. And a little practical thing, if they have a T-tube draining bile, you have to completely change where you put a gate belt. You can't put any pressure there.
Those are the details that really matter. What about for a kidney transplant?
With kidney recipients, you see a few things. First, that chronic bone loss from altered vitamin D metabolism is a big deal, so osteoporosis risk is high.
Yeah.
We also see a lot of overuse tendon injuries, especially in the Achilles tendon. And we have to watch their blood pressure response to exercise very, very closely.
So the long-term goal is what? Getting them back to a normal life. Maybe 30 minutes of continuous exercise a few times a week.
That's the goal. A customized plan, moderate exertion 4 or 5 times a week.
How do you get a patient with severe myopathy and osteoporosis to that goal safely?
It's all about customization and education. We start with low-impact cardio, like a bike or treadmill. For strength, it's very low resistance, high repetition with an obsessive focus on form, especially protecting the spine. You're constantly teaching them their new baseline.
And the evidence really supports this kind of structured approach.
Absolutely. The sources cited a study showing a 12-week rehab program significantly lowered fatigue scores in liver transplant recipients. And fatigue is one of the most debilitating side effects. So by restoring function, you directly improve their quality of life. Movement is potent medicine for them.
But the precautions stay for life. No heavy lifting acutely. Long term, you're always monitoring fall risk, and I assume contact sports are out.
Universally discouraged. The risk of organ trauma is just too high. The new organ is often unprotected.
And the timeline to even leave the hospital, that kind of tells the story of the challenge.
It really does. A simple, solid organ transplant, maybe you're out in 5 to 7 days. A liver, 1 to 2 weeks. Heart or lung, you're looking at 2 to 4 weeks. And for bone marrow, due to the immune system issues and GVHD risk, it can be 3 to 4 weeks inpatient.
Wow, that's a fascinating timeline. So we've covered the incredible precision of the matching, the HLA system, the lifelong commitment to immunosuppression, and how PT is this crucial bridge between just surviving and actually living.
It's the ultimate balancing act. And we've spent a lot of time on the physiological recovery, the myopathy, the osteoporosis, the infection risk. But here's the final thought for you. The journey involved these profound psychosocial concerns. Fear of death, PTSD, massive anxiety about rejection.
Of course.
We know functional movement is critical for the body, but consider this, how the diligent adherence to that physical rehab protocol, the walking, the strength work, is maybe the most immediate, tangible tool that patient has to actively fight the fear and anxiety. Functional movement doesn't just treat the body. It becomes a primary strategy for mental resilience, for taking back some control in a situation where they've felt completely powerless.
A compelling point. The physical act of getting stronger is the ultimate proof that the miracle has actually worked. Thank you for diving deep with us today.